Dr. Desiree LaBeaud, who is an associate professor of pediatrics infectious diseases at Stanford University. So, Dr. LaBeaud, you had a lot of research here at ASTMH. So I wanted to start with just asking if you could talk a little bit about some of the highlights of the research presented from your lab here this week.
Sure. So first and foremost, we're doing work on dengue and chikungunya incidence and prevalence in Kenya. Okay. And so one of my fabulous Kenyan collaborators came over. His name's Dr. Bryson Dengue, and he presented his work on documenting acute dengue virus infections in children in Western Kenya. So PCR confirmed dengue. And so this is really big news, actually, because there's a lot of talk that dengue isn't a big deal in Africa. And so we're actually documenting real dengue febrile illness disease in Kenya. So that's one thing. Dr. David Vu also presented our work on dengue and chikungunya exposure in our different communities all across Kenya. So that was another important finding. There's a lot of children who are being exposed to these infections all the time, and so we're not sure of the true health and economic burden of what's happening, but there's a lot of exposure, so it's more to follow up on.
Yeah.
And then Dr. Monica Singer presented her work from a Gates-funded study that is on the effects of parasitism on vaccine responses in children.
Wow.
And she actually didn't find an effect of the different parasites during development in utero or during early childhood or later in childhood, but what she did find was the really important effect of stunting and how that can actually decrease a child's ability to be able to respond to life-saving vaccines. So that was really important. And then Dr. Claire Heath presented related work on just the nasopharyngeal carriage of strep pneumo.
Okay.
Right now there's a vaccine that's given to children all across the world to protect them against invasive strep pneumo disease. And Claire's work showed all of these different serotypes that are actually not in the vaccine. And so probably the vaccines that we're using in Africa actually might not be the perfect ones. And there's a lot of serotype replacement, so children are probably still at risk for these really severe infections from strep pneumo. And lower respiratory tract infection is the number one cause of under-5 mortality in children across the world. So very important work. So that's just 4 of many. I could keep going, but I won't.
Well, thank you. That was a really great summary. My next question is something on a study that you also presented yesterday, looking at the discrepancy between test results, diagnosis, and treatment in the febrile illness in children in Kenya. So could you talk a little bit about what you found with that study?
Yeah, so this work was spearheaded by Dr. Annika Hooft, who's a pediatric resident at Children's Hospital Oakland, actually.
Okay.
And she, what we found in our study, so we're enrolling children who have febrile illness all across Kenya, and we're trying to figure out, is this due to dengue, is it due to chick, is it due to malaria? And so this study was really focused on characterizing provider behaviors, so really understand what's going on in the brains of healthcare workers as they see a child in an endemic setting with fever. Do they really think it's malaria? Is it malaria? Even if the blood smear is negative, are they still giving malaria treatment and so forth? And what we found was that for people who do have malaria, actually have a positive blood smear, we are doing a really good job of treating those children, which is great.
That's great.
But unfortunately, there's still a lot of children who have negative blood smears who the clinical officers think still have malaria, and they're still getting treated with antiparasitic drugs, which is not so good. So we have some work to do there. We also looked a lot at antibiotic use, and we found that even children without bacterial diagnoses, a lot of them end up getting antibiotics. And this sort of highlights the issue that, the reason why so many antibiotics are probably prescribed is that the clinical officers are uncomfortable because they're not sure the child's going to follow up if they get sicker. So when they have the child there in their clinic, they say, I've got you here, you look kind of ill, let me give you drugs for malaria, let me give you drugs for bacterial infections, just so I know you're covered.
Yeah.
And so I think what this work really means is that there's a lot to do as far as educating healthcare providers across the world on the other causes of febrile disease that aren't malaria, and then also there's a lot to do about increasing the infrastructure for actually figuring out the etiologies of febrile illness across the world, really figuring out what is going on so that we can use antibiotics and antiparasitics appropriately.
And so people really think about these viruses like chikungunya virus, other arboviruses, as problems that really don't affect us here in the U.S. And so they're kind of out of sight, out of mind. But what is your perspective on that? And can you tell us a little bit about what the risk is to us here in the U.S.? Yeah,
so it's a common thing that, people think of these things as sort of faraway infections that don't really have any relevance here in the U.S., but that is not the case. So, in fact, this morning I went to a symposium downstairs where they were talking about, the risk of chikungunya invasion into the U.S. And all along the border, there's already, local transmission popping up on the U.S.-Mexico border.
Wow.
And so these infections, although they're more common right now in other parts of the world, there's definitely risk to us here in the U.S. Why didn't chikungunya, as it went through the Caribbean over the last year or so, why didn't it explode into the U.S.? Well, it's true that we do live a little bit differently than people in the Caribbean. We're not outside as much. We have air conditioners, so there are some differences in behaviors that actually protect us from risk from these infections. But that being said, there's a lot of imported cases that come in because of travelers, and so in many of the places, including in California, we actually have the mosquito vectors that are necessary to support local transmission in our areas. Like actually in Menlo Park recently, Aedes aegypti was discovered, and the Aedes aegypti is the vector for dengue, for chikungunya, for yellow fever, for Zika virus, and some of these are emerging pathogens that are at our doorstep in Mexico, all throughout the Caribbean. And we know we have 9 million visitors to the Caribbean and South America each year in the U.S., and a lot of them are coming back to California. So you just need that perfect storm where you have an infected traveler that comes back that happens to get bitten by some local mosquitoes to allow transmission to start. And so I think it's really important as the imported cases come in, especially as a clinician, and then because we have these risks, to sort of have a global mindset when we think about these things. Our risk is probably less here in the U.S., but it's not incidental, and it's only really a matter of time before these infections come to a mosquito near you.
Well, then we really need to be paying more attention to this, it sounds like.
Yeah, I think so.
And does the weather contribute to that? So with the expectation that there will be more rainfall this year with it being an El Nino year, is that something to be concerned about? I know we were talking about that in another study with
Elise, probably.
Exactly.
Yeah, so I, for about a decade of my life, have studied something called Rift Valley fever virus, which I think you talked to with Elise. And this infection is really dependent on rainfall because these eggs that are sort of laid dormant are already infected from the mom mosquito who laid infected eggs. And so when the heavy rains come, you get a huge bloom of vectors, and that starts the transmission cycle. Some of these other infections, we're not exactly sure how much rainfall has to do with it, or temperature or humidity, but they're definitely environmental effects that are important. And as the climate warms, these infections are kind of they're climbing hills, they're going up in altitude, and they're spreading to new areas. And of course, when you spread these infections to new areas, you have this very large at-risk population. People who have never seen the infection don't have any protection against it. And so when the virus comes, you get these explosive outbreaks. And that's what we've been seeing with chikungunya right now as it's come to the Western Hemisphere. So weather is important.
So what inspires you the most about working in tropical medicine?
Ooh, that one's hard. There's so many things.
The most.
I guess for me, it's, a lot of the people, at least here at this meeting, and I think who work in tropical medicine really, again, have this sort of global mindset and really care deeply about other people in the world who are maybe less fortunate than them. And I'd say probably for me, that's the number one driver for why I'm in this. I want to look back on my life and my last days, which hopefully I have a few decades left, but you never know. And feel like, I really actually improved child health in the world. And I think that a lot of people here feel that way, and I think they're working towards, solutions. These are difficult solutions that take a lot of different people with different perspectives from different fields coming together to really tackle the hard issues, and there are a lot of hard issues, but I feel like, there's a need there, and there are definitely solutions to be had, and so I think just working toward that common goal is what inspires me most.
Great.
Copyright Stanford University, all rights reserved.